Okay, folks, it is 12 o'clock noon, excuse me, Eastern Standard Time. So we are going to get going in about 1 minute. We see a bunch of people filing in, so give us one more minute and we'll get started. Okay, folks, it is 12:01 Eastern Standard Time. We're going to get going with today's webinar. Uh, I'd first like to just say that this webinar is sponsored by MDaudit. Um, we are here to talk about benchmark insights for 2025 success. So we're going to talk a little bit more about this, but we're going to present MDaudit's 2024 benchmarking report, which is going to send you all home with some excellent insights for your billing compliance and revenue integrity programs. MDaudit is powered by AI technology, and really we help a multitude of clients across the country help minimize their billing compliance risks and maximize revenues. Before we dive in, I'd like to do some quick introductions and housekeeping items. My name is Dana Finnegan. I'm the Director of Market Strategy at MDaudit. Been here about 7 years. Prior to being with MDaudit, I spent about 25 years in healthcare on the payer side of the fence, the provider side of the fence, and now with healthcare IT. I'm also joined by our CEO, Ritesh Ramesh. Ritesh has spent well over 25 years in the healthcare space. He's helped payers, providers, and in big pharma as well, really helping them in the digital transformation and analytics space. So Ritesh has a ton of experience in helping organizations across the country as well. So we're really happy to be with you here today. Some quick housekeeping items. You will be receiving this deck after the presentation. You'll also be receiving the recording after the presentation. We are going to ask you to take maybe a couple of surveys, so feel free to do that. It's always great to get your feedback. You'll also feel free to enter questions. We will be addressing questions at the end of this session with about 5 minutes left. And finally, you will be getting a copy of our benchmarking report. We're going to, within the deck that we're going to send you, there's a QR code where you can request the deck. And most importantly, I think I would say you will get an excellent takeaway besides all of that. We guarantee you'll leave today's meeting with some very important nuggets that you can infuse into your billing compliance and revenue integrity programs. So I'm going to now have Ritesh take over and talk a little bit about MDaudit.
Great, thanks, Dana. First of all, thanks to the audience. I know today is a weekday for taking your time to join us, and we'll just make sure that every minute is worth your time. I just had a couple of slides, and I'll give it back to Dana. But first, what I want to start with is if we really look at the benchmarking report, which we put out there, there's a reason why we picked November of every year to put out this report. Number one is it allows us to look back into the year and look at what has happened. It'll help us look into 2025 and kind of predict or forecast few things. And more importantly, for all practical purposes, I know we have many customers who have joined us. This report is an excellent artifact for you all to use for your strategic and operational planning purposes going into the year, because I know that many of you are looking at building the compliance plan for next year, and hopefully this is useful. One key thing about the report, which is unique, is many reports are put out in the market, which are purely surveys. This report has a very rich sample size of data. If you really look at it, We have customers across 43 states. Many of you are in this webinar. Uh, the sample representative of charges are around $8 to $10 billion of audited charges. And if you really look at the denials, it's $150 billion. So the sample size is pretty large. And that's why we feel like most of the insights and takeaways from the reports are very representative of what's going on in the health system across the country. And you will see in the report that we have done everything possible where most of the data is aggregated. So you're not going to find anything in there which is very specific to a location or any of you. So I think this is one way to really drive value to the community, the MD audit community and the market. So with that, next slide, Dana. So I have this one slide. I'll get back to Dana. The way we have kind of published the report is divided into three sections. One is billing compliance, revenue integrity, and coding. And I know that in most of our customers and health systems, these three functions are working together more and more. So our intent was not to really, again, classify and create silos, but it's pretty much to kind of talk about some unique insights in these three areas. So if you really look at the first section, which is audits, there are three, I would say, eye-level takeaways. Number one is, if you look at 2024 as a year, volumes came back strong, and the main focus was on operational efficiencies and bottom lines. So that's the headline for the healthcare industry is as as the volumes kind of return, what are the health systems doing to make sure that they're doing more with less so that they can drive more healthier margins? So the first thing which you'll see is when we look at MD Audit as a platform, we saw prospective audits really increase 275% in 2024. And that's not a surprise because if we really look at what the payers are doing, the payers are really ramping up their reviews to be more prepayment versus post-payment. So what we see our customers doing is using a lot of analytics to retrospectively look in the mirror, understand what their hotspots are, and really being proactive to perform prospective audits. Our point of view is you still need to have a hybrid strategy of retrospective and prospective so that you can always kind of look into your rear view, understand the hotspots, and then proactively address them. So the first thing is we are seeing more and more um, intent towards doing prospective audits. And as we speak in MD audit, the split between retrospective and prospective audit is 60-40. And that's amazing because if you look at 2018, 2019, that prospective audits were almost like 0 to 5%, and now it has really ramped up to 40%. The second area is risk adjustment coding. There's been a lot of noise in this space. There was a Wall Street Journal article in July of this year, which is pretty much an investigation by the Wall Street Journal, which said that the federal government estimates that they have paid $50 billion in overpayments to commercial insurance companies for Medicare Advantage plans. And the article went on to say how the government is scrutinizing um, patient charts, which are being manipulated by some of these payers to add more and more diagnosis codes to get more payments. So it's no surprise that if you really look at the HCC audits and CDI audits in the platform, they exploded this year with 72% and 100%, because those plans are not only in the headline for pre-authorization, but those plans are also in the headline for overpayments and collections, especially for Medicare plans. So if you don't have HCC audits as part of your compliance program, that's something that I feel will be a big topic for the OIG and CMS in 2025. And we in MD Audit have been trying to do everything possible to have functionality which can spotlight and highlight the HCC audits as one area. And then the third one is if you really look at the auditor productivity, we define auditor productivity as something where we baseline the auditors and really look at how many cases were they able to review every year. And this year, again, the auditor productivity increased second time in a row by 35% due to technology and analytics. And in many cases, we saw that either the staff size remained the same, or actually in many cases, the staff size kept going down. So that's the power of technology and analytics is you still need humans, but at the same time, it's really ramping up productivity where folks are able to look at more risks. People are able to do more volumes, which hopefully will help versus doing manual processes and spreadsheets. And one thing which caught my eye was if you really look at the recent Department of Justice compliance guideline, they are heavily pushing a very data-driven approach and a continuous risk monitoring approach because that's what they are doing on their side, and they wanted the providers to do the same as well. So those are the three big points on the audit side and billing compliance side, and Dana's going to drill into more. And then the report, of course, has more details as you kind of download. Just moving on to the payment side, the first thing is the payment rates continue to decline across patient settings. So this year we saw the average dollar per claim across settings go down somewhere between 4 to 6%. And what's fascinating here is if you really look at the behavior between Medicare and commercial payers, they're paying attention on different places. When we looked at the Medicare denials, which was average amount per claim denied, it was more than 30% on the inpatient side. And when we look at the commercial payers, it was actually more than 30% on the outpatient side. So knowing the payer mix and where they're focusing on is very important because it gives you a good sense of probably the average is 4 to 6% at the system level. But if you really double click on the settings and the payers, we saw like egregious amount of denials. Some of them are more than 30%. But that's the key takeaway is more claims are being denied and the average dollar per claim keeps getting denied more. And that is the story in 2024. External payer audits. This is one interesting area where we have been watching the space in terms of where this is going. And one thing we saw was when we really look at the at-risk dollars per MDaudit customer in 2024, that was around 11.2 million. Last year, that number was around 2.2 million. So there's a 5x increase in terms of the at-risk dollars. And of course, most of it is coming from the hospital side. And then when it comes to volumes, the volumes increased almost 2.2x. And we are hearing from a lot of our customers that this year, many of these audits are getting more and more prepayment versus post-payment. And that is not a surprise given the fact most of the payers are slowly starting to go from post-payment reviews to prepayment reviews, which has been a trend. But external payer audits is something which we will continue to watch. And the fiscal year for OIG has already started on October 1st. So I'm sure that the RAC, MACs, and TPEs are active as we speak, looking at FY25 and what needs to be done in the space. And last but not least, it won't be a surprise for anybody. When we looked at the Medicare Advantage plans, they continue to get scrutinized. And there was an 87% increase in inpatient denials and 36% increase on outpatient denials. Again, these plans are offered by the commercial payers for Medicare patients, and it purely operates on patient acuity and severity, and there are value-based payments. So the government is really, really looking at not only the claims submitted, but also the charts, and even going a step forward to see whether those charts were manipulated by the insurers, because they have the ability to override what a physician wrote on a chart. So I do think that most of the Medicare Advantage plans, although they are being audited by the government, it will come back to most of the providers because that's where the services are being provided. And as the federal government tightens the budget, this is one area where they're planning to take more and more money out and make sure that they reduce fraud, abuse, and waste. And the third piece is coding. And this is my favorite topic because we all hear about autonomous coding. There's a lot of marketing in the industry going on. And one fascinating fact is if you really look at the coding related denials this year, it's skyrocketed 126%. And I was thinking to myself that, oh my gosh, like if all those autonomous coding technologies are working great, this number should not be 126%. It should be probably less than 10%. But I think the biggest insight or our hypothesis is as people are zeroing in on technology, where these denials are happening is in the last mile, which is I think there's very little investment and focus being put on the humans in the loop. This is with your coders, coding teams, some folks outsource coding. So, what type of coding integrity programs are being run to make sure that you don't have autonomous coding engines which are amplifying errors downstream, and then humans are being coached to catch them and improve with continuous coder education. So I do think this year, as more and more vendors ramp up their autonomous coding technologies, there'll be more and more spotlight on coding integrity programs because there is an inherent risk here that if the engine gets it right, it's great. If it gets it wrong, you're not going to have one claim. You're going to have thousands of claims where the errors are amplified downstream. So I think that's one highlight is in our report, we focused on making investments on coding integrity program. And then if you really look at 126%, where those coding denials are coming from, no surprise, it's on the inpatient side where it was more than 200%. And then outpatient still contributed to more than 30%. So those are the three categories and key takeaways and executive insights. And I'll just give it to Dana to drill down on each one of the billing compliance, coding, and rev integrity areas to walk us through.
All right, great, Ritesh. Thank you for the intro. As Ritesh said, we're going to break up the remainder of this session into three distinct parts: billing compliance insights, revenue integrity insights, and coding and HIM insights. Just as you know, we're going to send you home with some nuggets that you can really infuse into your programs. But we're going to go down a level, talk about some detail. But I also want you to know that when you get the report, when you come to our website and download that report, the report's going to have a multitude of other information and detail down to the CPTs and DRGs that are being scrutinized and who's scrutinizing them and why. So make sure you get that report as well, because it really drills down to very specific stuff that you'll want to see. So the first insight in billing compliance is through the use of technology and analytics, we've seen substantial productivity and efficiency gains within our auditor population. So you can see on the left-hand side, in 2024, there was a 35% increase in the number of cases or claims an auditor could actually get through. And when you extrapolate that, it's going to be just really increasing the amount of audits the auditors can do in our platform. And the coolest part about it is it goes along where they didn't have any increase or even had a slight decrease to their team. So more work getting done, more claims being audited, more audits being done, leaving more time for education, even when teams FTEs stayed the same. It had a slight decrease. So the second bullet kind of addresses how that happens. So how does that happen if you have less folks on the team? Well, really increasing the volume of cases through a risk-based, data-driven approach. So that really enables the billing compliance function to really hone in on, where are underpayments happening, where are overpayments happening, and that's done through running the billing through analytics, benchmarking versus CMS versus the CMS community. How do your providers compare to that? So although teams have seen a decrease in FTEs or stayed the same, volume is going through the roof when this type of technology is employed. Now, really, that last bullet talks about winners and losers in this space. The payers that we're all trying to fight the good fight against, they've invested quite a bit into their budgets for AI and analytics to find the claims of yours so they can deny them at record paces. So you need to do the same thing. You really need to invest in technology that can make sure auditors are deployed to the highest risk areas. Again, if you're still dependent on spreadsheets or requesting data from IT and waiting for those samples, it's really putting you in a very precarious position versus the payers who are so bulked up with this technology. So think about it. We really think the greatest approach is to do what we call CRM for RCM, constant risk management and monitoring for revenue cycle management. And if you're able to identify risk immediately and act upon it, you will definitely retain more revenue and bill more compliantly. So at the end of the day, what I want you to take away is volume and productivity and efficiency can go through the roof if you partner with the appropriate vendor. The second insight we want to talk about, and Ritesh kind of talked about this a little bit, but we're going to go into more detail, is the increases we're seeing in retrospective audits and prospective audits. So we have seen a massive shift for our organizations, folks in billing compliance and revenue integrity. Really, retrospective audits have gone up 10% in 2024, but the 275% increase in prospective audits, just again through the roof. And that has happened over time. But this year we saw a huge increase in prospective audits. And why? Well, because folks are trying to get ahead of before claims go out the door, make sure they're billed compliantly, they meet the highest levels of accuracy and integrity, and so on. Now, also, if you think about it, you can run, and this is happening in the MDaudit community, a lot of folks can run analytics and benchmarking and AI over their billing patterns and help them identify high-risk DRGs, providers that are habitually overcoding, providers that are habitually undercoding, through that retrospective data. And when I say retrospective data, I mean claims data, denial data, and so on. But then you can then take those systemic issues, those providers that are habitually undercoding and overcoding, high-risk DRGs, and put them into a prospective auditing mode. So a lot of folks will say, well, these analytics are telling me great things, but what do I do operationally? Well, you can then operationally start putting those providers on a prospective audit basis. Auditing prospectively a lot of those high-risk DRGs, HCCs that are being highly scrutinized, CCs and MCCs that are being highly scrutinized. Having the insights allows you to then put those things into a prospective auditing mode. And that will equate to cleaner claims, higher first-pass pay rates, less days in accounts receivable, and constant cash flow. So think about it. If you're not employing that hybrid approach of retrospective and prospective, even leaning more towards a prospective auditing model, that is something that we really suggest you do. It'll definitely help you ensure that before bills go out the door, that they are getting the appropriate look that they need, and that they're being billed compliantly and maximizing reimbursements. A third thing that we want to talk about, another huge increase, is risk adjustment and HCC audits. So you can see there's been a 72% increase in 2024 over 2023. Why is that? Ritesh kind of mentioned this a little bit, but we want to drill in a little bit more. So there was you can see that first bullet, government identified over $50 billion in overpayments specifically related to the billing of HCCs. Hierarchical condition codes. So what we really suggest here is, and we talk about prospective audits, these are being highly scrutinized, HCCs, particularly for Medicare Advantage plans. If you're submitting HCCs to a Medicare Advantage plan, chances of you getting audited, denied, are incredibly high. So this is something that would be a great example of get a sample size of HCCs being billed and audit them prospectively. Make sure there's no improper billing or coding, because that will absolutely lead to heavy fines and penalties from the government. So really, you want to at least dedicate some of your audit plan to HCC specific. You want to make sure there's no systemic, fraud or abuse. And not that it's intentional, but it can be viewed that way by the government. So again, great opportunity to take these HCCs, and we'll talk about CCs and MCCs later, and prospectively audit them, particularly when they're going out to Medicare Advantage plans. This is scrutiny that we expect to go up even more as time goes on. Last section in billing compliance I wanted to talk about was kind of really stunning statistics. So you can see that more than 25% of providers in the MD audit community, when they were audited, failed audits across both the professional side of the fence and the hospital care setting as well. So on the left, you can see 33% of rendering providers failed audits on the pro fee side, and 23% of attending providers failed on the facility side. Now we know a lot of that is being coded by coders, but these are we'll get into coders as well, but these are really kind of eye-opening failure rates. Now, what we'd like to take away from this is not only do you need to audit your physicians, rendering providers, attending providers, both retrospectively and prospectively, but where we see a lot of organizations kind of falling flat a little bit, or I should say need to be a little bit more robust, is with their educational and compliance programs. It requires transparency. And if you think about it, if you automate some of those processes, and we're going to go back to a prior insight, you have immediate insights through AI and technology of who your undercoders are, who your overcoders are. You're able to put your FTEs in the right place to do those audits. That is going to leave a heck of a lot more time for education. And we've seen when there's camaraderie between auditors and providers with that education, and they're bringing real insights from claims data, denials data, and audit data, and putting that in front of the physician and having kind of positive dialogue. That is reaping tons of benefit. The education program has to stop being punitive. You want to go there with the right reports, the right bell curves, all of that data that we're talking about that can be at your fingertips through technology, and it really helps engender healthy dialogue with physicians. The last thing I would say about that is the program has to be scalable. So you want to make sure, again, that if you have a mandate, if your mandate is still audit every physician once a year, we understand that, but please, again, try to take a risk-based approach as well. Try to vet out those physicians first that are undercoding and overcoding habitually, and then once that's done and those physicians are educated and making sure those patterns don't go through the roof going forward, you can mitigate those by hitting your highest risk providers first. And then once that's done, go into those more ad hoc audits with the rest of your provider audience. So just if you haven't done it, really run some statistics on who's failing, why they're failing, and institute a very collaborative education program. Where I want to go next, we did billing compliances. Let's jump into some revenue integrity insights. So the first one, you're going to hear me use the word staggering, but I'm going to use it again, is let's talk about the average denied amount per claim on both the pro fee side and the facility side. So what we saw, if you go to from left to right, the first visual here is in every care setting, pro fee, outpatient, and inpatient, we saw a 4.2% increase pro fee, 4.8% outpatient, and 6.9% increase from 2023 for average denied amount per claim. And if you think about that, almost 7% on the inpatient side, that is absolutely unbelievable because of the cost of having to take care of those patients with long inpatient stays, with CCs and MCCs, very acute patients. Huge cost to the organization. Almost a 7% increase in average denied dollars it can be crippling. Now, if we go into the middle, what we're seeing is Medicare Part A on the inpatient side this year had over 30% increase in their denial rate. So it was largely being driven on the inpatient side by Medicare Part A. Now, on the third visual, you can see the commercial insurances on the inpatient side, kind of less scrutiny on the inpatient side, but then brought that scrutiny to the pro fee side. So you can see commercial insurance increased from 2023, 30%. So what I'd want you to take away from this slide, and we're going to jump in a little bit more, is increase from 2023 to 2024 has gone up in all care settings, but you really want to run some audits, prospective, retrospective, and look at your denial population as well and find that root cause of what's causing that 30.2% increase on the inpatient side and that 30% increase on the prophy side. Because if it's happening in the MDaudit community, those of you that are not in the MDaudit community, it's happening to you as well. And what we can say is on the Medicare Part A side, that 30.2% increase on the inpatient side of the world, that was Medicare Part A really zeroing in on inpatient services to very complex Medicare population. So again, you want to look and see what's denying for Medicare, particularly those patients with long inpatient stays, with high-risk DRGs like sepsis with vents over 96 hours, where they have CCs and MCCs. That's where you're getting denied. You got to go in and take a look at those. Find root cause. Make sure you're appealing those within timely filing limits. Understand the payer policy and so on. Where on the pro-fee side, that 30% increase was largely driven post-COVID with office and emergency department visits. Commercial payers are absolutely scrutinizing E&M levels, but more importantly, your ED levels on pro-fee claims. Now, again, when you get the report, when you download the report, you're going to see the exact codes for E&Ms, for ED visits, for high-risk DRGs. You'll get all of that back up if you go in and take a look at the report. But the takeaway here is absolutely getting bombarded on the inpatient side by Medicare Part A and bombarded by a bunch of different of the commercial insurances on the pro-fee side. One of the things that is really making people scratch their heads, and I'll tell you why, is we're seeing payers are doubling down on the denial dollars associated with medical necessity and information for medical necessity and information needed and documentation needed. Why are they doubling down on it? My opinion, I'm not trying to malign the payers, but if they send you a denial that says, we need more information, this didn't meet medical necessity, or maybe it's something like some claim has submission error. I mean, you're scratching your head because you have no idea what to do with those. It's not telling you anything actionable. So again, before I even get into these stats, you want to partner with a vendor that has the ability to get down to the next level of granularity for those type of denials. Think of it. The claim adjustment reason code, the CARC, is going to say missing information, doesn't meet medical necessity. You need a vendor that can help you drill down to the remark codes and other attributes on those remits to help you understand root cause. Now, let's talk a little bit about these statistics. So you can see on the left-hand side, hospital inpatient denied dollars for these categories went up 148%. Unbelievable. Outpatient, 84%. And professional, 34%. They're all jumping in on this game and throwing you out these very vague denial reasons. Now, the payer types, we saw the biggest increase for Medicare Part A for these RFI denials was 56% Medicare Part A, but your commercials are 122% of this as well. So what can you do about it? First of all, we expect them to continue these denial categories. They are specifically, when we dug into our data in the MDaudit community, folks are specifically getting these denial categories for complex diagnoses, CCs, MCCs, HCCs, specialty drugs, high-cost drugs, medical implants, pacemakers, and really just high-cost treatments. And again, if you get the report, you're going to be able to get all the codes and all of the stuff we're seeing as the backup so you can add it to your audit plan. So you want to know what services particularly you're going to get these denials for. And the next thing is to really kind of dive into the payer policy and figure out what do they need? What documentation are they looking for? And of course, not only understanding the payer policy and kind of diluting it to understand that, but really tighten the CDI program. So go in there and where you're getting these medical necessity denials, you want to go and specifically map that back to the attending provider and the coders that are coding these cases and say, this is where you're lacking in the documentation. If you were able to say this in your documentation, then we would be able to basically bypass these denials. We'll have the medical necessity verbiage that they are looking for. I'm not saying that's easy. Payer policies can be thousands of pages long. Again, work with a vendor. There's many vendors out there like MDaudit that can take in a payer policy, dilute it, and tell you, even on a pre-bill basis, why things are going to deny and how to fix them, because we understand the payer policy and what they're looking for, what information they're looking for. It could be as simple as tacking on a clinical trial number within a loop and segment on that claim for a pacemaker. Or it could be that they're looking for copious documentation on why you went with a certain therapy as opposed to another therapy. Vendors have that information to help you fight this good fight. MDaudit has really helped folks do that. But again, you want to take away, you will see if you dive into your denials that medical necessity, information needed, documentation needed are at the top of the list of your denials, and you need to understand that more. Here's something that is also scary. So I always take it and say, you can be fantastic at fighting denials. Some of you are saying, my first pass pay rate's 98%. That is awesome. And you can be great at billing compliantly. That said, you will still be receiving payer audits. We saw that payer audit at-risk dollars from payer audits, we're talking RAC, MAC, commercial payers, SMRC, UPIC, all of them, that in 2023, the at-risk dollars for them was around $2.6 million. In 2024, though, that at-risk dollar population being scrutinized by those folks I just talked about went up over $11 million. That's a 5x increase happening in the MDaudit community. I'm sure those of you that aren't yet in the MDaudit community are getting bombarded with these ADRs as well. Additional documentation requests, demand letters. End of the day, they're trying to claw back your hard-earned revenues. So you want to know what they're scrutinizing, where these letters are coming from. That's all going to be in our report. Again, what DRGs, what CPTs, what modifiers are they trying to do these clawbacks with? Download the report. What we're finding is a lot of folks are having a lot of problems responding to these in a timely manner. You get these letters, you got 30 different facilities, they're sitting on someone's desk. You really need, again, a technology that helps you automatically ingest those letters and help you get all that information so you can start fighting a good fight, not have to rely on spreadsheets and kind of manual processes. So again, many revenue integrity departments are struggling to defend revenue because they have limited resources and trying to do this manually. So come and take a look at MDaudit or a vendor that can really help you optimize your response times. Really, another thing we would talk about with these audits is they were post-payment in 2023. We see a huge shift in 2024 to them doing these on a prepayment basis, which will then equate into more denials and an absolute constraining cash flows. So again, you got to be ready for these post-payment and prepayment and have the technology needed so you're not just entering all this information from the letter manually. You need technology that can scan those letters, upload the information for you, and even things like ESMD, like the electronic submission of medical documentation, that helps you send all of your appeals documentation right back to the requester electronically, so you're not mailing, faxing, printing. You've got to make sure you're not missing those deadlines. So our view is investments in technology and analytics that help you fight these ADRs are really going to help you do it within timely filing limits so you can defend and retain revenue. If you want to find out more, again, dig into this report. One thing I would mention, MDaudit's really proud at helping customers fight these pesky letters. In the last 12 months, through the use of our technology, the MDaudit community has retained well over $100 million in revenue that was trying to be clawed back. They have retained it through technology. So at the end of the day, these are going to be coming fast and furious, more than 5x than what you've seen. be ready to defend them. Know where those letters are going, process them immediately. Don't forfeit your right to your hard-earned revenue. Now we're going to get into the coding and HIM section. Last section here, and then we're going to do some questions. Let's talk about coding-related denials. Here's something scary. Coding-specific related denials. So we're not talking about timely filing. We're not talking about authorizations, pre-certs. What's that? Coding-specific denials increased by more than 100% in 2024 over 2023. If you look at that first visual, the average denied amount for a coding-related denial was about $300, a little less than $300, $297. In 2024, well over $600. That's a 126% increase. And you can look at it on lower on the pro fee side, outpatient, inpatient, but essentially look at inpatient. 219% increase from 2023 for coding-related denials. This is scary because if you think about it, we hear a lot that a ton of your coding-related billing is being outsourced. Okay, so you don't have as much control over it as you should when you send it to, you're maybe outsourcing to another vendor to do that coding. Another piece of it is a lot of folks are adopting, as Ritesh said, autonomous coding technologies. And we're not saying that you shouldn't outsource. We're not saying that you shouldn't use autonomous coding. What we're saying is it's not fully baked yet. You really need to have a very strong governance and QA process over that autonomous coding technology, as well as the vendors that are doing your coding, because there are gaps there. Payer scrutiny is going to continue and continue and continue, particularly for those inpatient cases with CCs, MCCs, HCCs, and so on. So, and again, that relates to this 219% increase on the inpatient side. You've got to do some prospective audits of what's going out to the on the inpatient side. You again, HCCs, CCs, MCCs, high risk DRGs, and you've got to have people in the loop. Ritesh mentioned this, people in the loop all the time. If you have an autonomous coding engine, great, but you need people in the loop to check the findings of that autonomous coding engine, because if you don't, there can be some real devastating effects because the autonomous coding is not, again, fully baked yet. So our thing is be aware of this. Coding-related denials are going to far outpace your authorization denials, your timely filing denials, your credentialing denials, and so on. Make sure you have people in the loop that are doing audits, understanding those denials, root cause of those coding-related denials, and again, have the ability to map that back to the coders that are coding for these services. And you need to not only identify your coders that are coding these services that are being denied, but educate them, just like we talked about, a very healthy dialogue with your coders as to why these are denying, and help them understand what they can do better when coding these services. Now what we want to go into, we talked about coders a little bit, is we talked about physicians' failure rates, but more than 50% of coders failed audits, again, across the pro fee and hospital settings within the MDaudit community. What does that tell those not in the MDaudit community? Is you should be auditing your coders on a regular basis, educating them. You should have analytics at your fingertips, just like the MDaudit community does, of who are your good coders, who are your coders that are struggling with accuracy and integrity, and so on. What I put in here, and we have the codes that back all this up in the report, but in the upper left, we show the top denial reasons on the pro fee side. On the right, the top denial reasons for coders on the outpatient side, and then below on the inpatient side. You'll get a chance to look at this, but I think the category that appears on all of these is, you can see here, $285. Payer deems the information submitted does not support this level of service. On the outpatient side, same thing, $849. Highest reason, denial reason, payer deems information does not support this level of service. On the inpatient side, we also have $5,000 a pop. Payer deems this information submitted does not support this level of service. in all cases, whether it's pro fee, inpatient or outpatient, payers are doubling down on the coders that are coding these services and saying, essentially, you're overbilling us. It doesn't support the level of service you're billing. This is really where, again, we need to have integration between what's being coded and the CDI part of it. Make sure those medical records truly have the documentation needed to support what is being billed out on those claims, because payers are always looking to downgrade what you're sending. We all are fighting DRG downgrades and other downgrades. Another thing that jumps out at me here is, especially on the outpatient side and particularly the inpatient side, is huge amount of denials for diagnosis codes, whether they're not valid, not covered, or it's inconsistent with the procedure. It's a great opportunity to not only drill down into your denials to find the denial for what's not supporting the level of service that's billed, but drill down and find out what diagnoses are invalid, which ones are inconsistent with the procedure. That can then help with your dialogue with coders and say, these are diagnoses you can't use. These are diagnoses you can use. Get everybody on the same page. So takeaway from this is audit your physicians, but never, never, never forget to audit your coders on a regular basis. And, provide them with education as well. And once that education is provided, particularly for those that are failing, make sure you have subsequent audits planned as well. Don't let them off the radar until you see a significant improvement with their coding related accuracy and integrity. So folks, that was kind of some insights from billing compliance, rev integrity, and coding in HIM. Again, we want you to take this information, infuse it into your audit plan, your revenue integrity plans. In the report itself, we'll have a lot more granularity that'll help you do that. What we're going to do right now is I'm going to pass it over to Ritesh to give some closing thoughts. And then after that, we are going to have Joy throw out a couple of questions that were asked during the process, and also pay attention to any, if you will, we would appreciate it, any surveys that come up. We want you to take those as well. So Ritesh, I'm going to turn it over to you for some closing thoughts.
Thanks, Dana. So the four closing thoughts I had was, one is, given all the things that are going on in this environment, invest in technology, automation, and analytics. And for folks who have already invested in it, I think basically risk-based analytics as a key approach to drive operational efficiency, because I do think all of the programs going into 2025 is going to be pushed to be operationally efficient. The second thing is, as we walk through these three sections, it's very clear that all these functions have to work together. So we try as much as possible to bring together these functions, but I think the key thing is to make sure that you have cross-functional teams working together, you have informal steering committees where you can share information, be transparent, and work together towards some common business goals. That is kind of key. And then third thing, which is key, is as things are moving so fast, use of real-time data becomes very important, because what you are looking at 6 months before or 3 months before may not be relevant last week and a couple of weeks before. So I do think using as real-time data as possible will help you identify some trends and then drive corrective action. And then last but not least, we talked about data insights and technology, which is all great, but I cannot emphasize how the training and change management of your people, as you kind of transform the function and use some of these data sets and tools, are more important. So I do think it's very important to train your people and take them along the journey. So those are the four closing thoughts we add. And again, as I said, the report is available. And as you review it, reflect on it, we'll be more than happy to answer any questions, even outside of this webinar. This is the QR code, which is on the deck. If you scan it using your phone, you'll be taken to a MDaudit.com webpage where you can download the benchmarking report. And we had one other slide. And if you need any questions or comments on learning more about MDaudit, you can use this code as well. So we thank you all for attending the webinar. And Joy, is there any questions? We'll take some questions now.
Yeah, we have questions. The first is, do you take input our organization specific payer plans into the system?
I could answer that. Ritesh, do you want to take that? It's up to you.
Yeah. So I mean, we do have. So I didn't understand the question. Is if the question is around specific payer plans? I'm reading that as payer contracts. So today in MDaudit, we have supplemental data where we are working towards taking some of that information in, but there are ways where our customers configure their payment rates and conversion factors. Hopefully that answers the question.
Okay, we have one more. Is this reporting Dana speaks of, Dana keeps referencing, an add-on to the regular MDaudit software? I assume it is and will require getting EOMBs from payers to gather the data for the report.
Go ahead, Dana.
I'm not totally clear on the question, but what I would say was MDaudit has the ability, I think this is what we're asking, is we talked a lot about denials and how to get to root cause of denials, why payers are denying things. So MDaudit not only has the ability to ingest your claims data on a daily basis, to run analytics over claims, to find overcoder physicians, undercoder physicians, high-risk DRG patterns, and so on. But we also have the ability to ingest the corresponding 835 EOBs, remittance advices, whatever you want to call them, so we can help you categorize and immediately understand root cause of denial. So if that is something that you're interested in, please let us know. And that's something MDaudit can absolutely do is interrogate, read your remits and help you understand systemic hotspots of denials.
Yeah, that's right. And I think that's a module called Revenue Optimizer in MDaudit. And if you're interested, please feel free to reach out and we can talk more about what it does.
Yes. So folks, we want to give you back a few minutes as well, and I know I've pounded this a thousand different times, but we really encourage you to visit our website. Also go to this deck. You'll be getting this deck, download the report, because all of the stuff down to CPT, DRGs, different things, RAC, MAC, who's scrutinizing what is really in there to help you guide yourself for something that may not be on your audit plan that you're not aware of. So we appreciate you joining today, and we hope to see you in future webinars as well. And we thank you for your time.